Well, look, to be honest, I only really got notice of this yesterday as I set off. So I wouldn't have come to talk to you myself. I'd have sent my statistician to talk to you because I'm not a statistician. I'm not an epidemiologist either. I just happen to be in charge of a big cohort, which has caused me some trouble. But I think that I learned quite a lot from doing this, and what I'm going to do is just go through the problems that we had. And I remember some years ago the excellent POPs study did a review of their cohort at 19 years, and actually ended up with a very small proportion of the children followed up. And they then imputed outcomes for everybody, and then reported only imputed outcomes. And I got myself quite worked up about that because I didn't think that was the way to do it. But I didn't know any better, and so that's why when I came to look at imputation, I found it quite challenging to know quite exactly how to report it, and to how to report what you've done. So I thought I'd just take you through our bit, and I think you just have to understand a bit first, a little bit about what we've done. We have two studies. One of them are babies born in 1995, and the others are babies born in 2006. The populations are slightly different. One covers all of the British Isles, the other covers just England. And one has been followed longitudinally, and we're just starting a 19-year follow-up on them. And the other one has only been followed through till about 3 years. But the difference in 11 years is astonishing because, is this a? Yeah, it's a pointer. Excellent. Oh, I don't even have to move. You see, we had equivalent of 371 in a year across the whole British Isles in 1995, and then we had an almost doubling of the numbers of babies by 2006. So we're still trying to work out why that has happened. Okay, is it a statistical fluke? Is it that we had we chose a bad year for births in terms of the numbers, or is it due to a real change in people's attitudes and behaviours? But we've got these two studies, and both of them we've actually used some degree of imputation. Now, because we had whole perinatal data sets, we were able to compare. If we just took the English children from here, we were able to compare very nicely the prevalences of various interventions in that group. And we had 100% data in both of those studies, so there's no problem there. And so when we look at survival, we actually know that that's what we're looking at, and that these are significant findings, significant increases in survival, so there's not a problem. And we also know that we've collected the data in terms of our neonatal outcomes in exactly the same way. So we can be reassured that when we do the comparison, we know things are okay. Now, let's take the first problem. The first problem is looking at EPICure. And we have done 3 evaluations on that cohort. And if we look at the first 2, the first is that when we say someone has a particular category of impairment, we sort of take that as read, but actually those individuals don't necessarily listen to you, and they change their abilities over time, and so you end up with children who you classified at 30 months as severe, who end up actually not being severe at all when you see them at 6. And if you're in the no disability category at 30 months, you find that people actually acquire disabilities between 2.5 and 6 years. So in an individual basis, actually your predictive value is not very good. So you're dealing with a very, very movable feast, and there are a whole bundle of reasons for that that may be important. And then we end up with our categories of disability. And if we look at them over the 3 assessments that we've done, you could conclude, whoops, that wasn't supposed to be in there. You can conclude actually that the rates of disability have hardly changed in terms of moderate or severe, but that the children appear to be getting better. They appear to be fewer children with severe disability. And the problem is, what does that actually mean? Well, the problem is that reducing, and are we measuring the same thing? Well, the first thing is we don't know that we're measuring the same thing at each age. We're using the same broad definitions as put out by the WHO, but we actually don't know we're measuring the right thing. But the other problem we have is dropout. And you can see that at 30 months we had full data on 283. At 6 years we had full data on 262. And at 11 years we only had 219. And that says 309. And that's because we found another patient who wrote to us and says, hey, I'm not in your study, but my baby was born actually at 24 weeks in a hospital in England in 1995. So we had to include her. And theoretically, we should go back and redo all the statistics, but I think that's just a little bit too much difficult. And of course, who are the children that you don't see later on? Those children are probably much more likely to be those who have severe disabilities. Because why does the parent want to come and have an assessment when she knows her child is already disabled? And just to be told her child is disabled yet again. So there's a bit of altruism in coming forward, but there's actually very little to be gained for the child. Whereas actually people in the middle here often come to see how their child's progressing and whether they're catching up or not. So that's one of the reasons that actually we see fewer children in this category at 11 years. But because we have got data at each of these time points, and we have 100% perinatal data set, we can actually make some stab at giving a figure of what it ought to be in that group. And you might call that imputed. I suspect that's the wrong word for it. I suspect what we've done is we've actually substituted values, okay, which is a very different process. But my statistician tells me no, she did it by imputation. She did it by multiple imputation, which is, to my mind, and this is going to sound ridiculous to you lot, but it's like doing a regression on dropping bits of data the whole time. You do it many times and eventually you come up with the view. And she came to the conclusion that actually 55% of the survivors, if we'd seen the lot of them, would have had moderate or severe impairment, which actually is pretty close to the 50% that we had when we saw them at 2. So I feel that's a reasonable use of imputation, and I have not reported anything in terms of imputation figures other than the fact that we have just confirmed this by doing imputation. Yeah? So you can't read that. When you read the paper, you read exactly the children we see and the problems they have, and then you have a statement at the end saying that if we use imputation on the major outcome, that we see those values. And I think that's the right thing to do. The problem is a little bit bigger when we get to EPICure 2, because not only were there many more survivors under 26 weeks, but survival was in much, much better. And because survival was better, rather than just 300 survivors to follow up, we had 1,000 survivors to follow up. And we weren't ready for it, that's certainly true. And also in the time frame of those 11 years, people's attitude to research in the UK, and I don't know if it's the same around Europe, but in the UK, there's immense suspicion about research now, and people don't like bringing their children back. for research evaluations. If we look at routine follow-up across the country, which is actually mandatory under the NHS, we probably see people are achieving 50 to 60%, which is actually pretty close to the proportion that we saw face-to-face, yeah? So that's not good. There are certain pockets where we see over 80%, but actually the days when we used to get 100% follow-up are now relatively light, and it is really difficult to do it. So we saw 576 children face-to-face, and we got another set of data from local records on children after 2 years of age, and 191, which meant we could claim that we had follow-up information on 75% of the cohort. But actually, we probably only had data on 55% collected in the right way, yeah? So we had a challenge, and we had to work out how we were going to analyze this data set. The other problem was that the tests had changed that we used, yeah? And we were not using the same developmental test as we were using in 1995. I don't know if any of you know much about developmental tests, but there's a wonderful theorem by a guy called Flynn, and he came to the conclusion that if you standardized an IQ test and then you used it continuously over the next 20 years, actually the mean scores would rise, okay? And that wasn't because people were getting brighter, it was actually that they were getting better at doing the tests, yeah? And that's actually quite important. You know, my mother, who's 94, has spent the last 40 years not knowing what a remote control is, okay? My friend's children, who are 12, 15 months, know what a remote control is. And so societal values and things change, and it doesn't necessarily mean you're brighter, it just means that you're dealing with different situations. And the Flynn effect you can see in the Griffiths quotient, for example. When we did a study using Griffiths about 20 years ago, the Griffiths were standardized in the 50s, and we were getting control arm scores of 112 and 114 when they should have been 100. So that when you re-standardize the Griffiths, the mean should be back at 100 again, okay? They redid the Bailey scales about 5 years ago, and when they re-standardized them, the scores were 7 points higher than the old scales. And so we have no comparability between the old and the new scales at all. And that's quite challenging. So let's just go and see what we found when we looked at it. The first thing we found was that this is the EPICure 2 cohort, that we had, whereas in the past we'd had very similar results between 22 and 25 weeks, we found that there was a gradation improvement in the categories of disability, such that at 22, 23 weeks, the results were much the same as we'd seen in 1995, but at 24 and 25 weeks, they were significantly less. The other thing we found is that cerebral palsy was difficult to define and almost impossible to define if you let lots of clinicians do it. So the diagnosis of cerebral palsy was derived from a neurological assessment, not from someone saying the child had cerebral palsy. And they were all done by me, and they were all done in the same way, so that we made sure that the data were consistent across the two studies. And the great thing about this was that we had about 14-15% overall in the original EPICure cohort who had moderate or severe cerebral palsy. And here, grade 3 through 5, actually seems to have reduced to 9%, 5%, and 4%. And that compares to 2% at 26 weeks. So we can see some improvements, we think, in where we're going. Now, this is what the Bailey scale had done. And this is what we tried to put this right by taking a group of about 170 children, so actually almost as much as the standardization population, and we developed a mental scale out of the language and cognitive scales, and we also completed all the items to do the old Bailey 2, and we found that actually they didn't seem to correlate very well at all. In fact, there was, here's the line of unity, this dotted line up here, and here is the correlation. And you say, well, it's reasonable, you know, it's reasonable. But of course, you're not supposed to compare two tests like that. You're supposed to compare two tests using a Bland-Altman plot. This is the Bland-Altman plot. And instead of just putting in confidence intervals in parallel to the x-axis, we actually put in the regression line and 95% confidence intervals of the actual correlation. And you can see that actually at high Bailey 3 scores, actually there was just a little bit of an offset. But that once you get down to these low scores, there's a huge offset. And therefore, not only was the Bailey scales being more generous, but at the lower end, the Bailey scales were actually seriously overestimating the children's performance. And the only way we could relate that was by doing a polynomial regression and then using that polynomial regression to derive a new Bailey score, which we did, which I think was fine. The question is why that happened, and it happened because of political correctness in the American psychologists that were doing the restandardization. And what those American psychologists did is they took the population and they said, well, look, hey, this population is much better educated than they were when we did the original one. So we're probably overestimating what we're doing. So they then went along and they added in 10% of children who they knew had problems. And so they added in those 10%, and that's why, after they'd normalized it, they suddenly find that the bottom end is overestimating it. Because those children who had impairments actually are included in the standardization norms. Yeah? Have I explained that clearly enough? Yeah, okay. So these are our predicted scores. And they range from 80 for 22-23 weeks up to 92 for 26 weeks. And actually, if we look at the mean change in MDI, we think that there's been an 8-point improvement. And those are the 95% confidence intervals on that. And maybe we should do a propensity score to see whether we've actually really achieved that when we look at it. Maybe there are other things that are coming along. But certainly that seems to be the way things are going. So we've got some pretty robust data, and we've thought long and hard about how we've collected those data. But we only have data on 55% of the set. Now, can we rely on these data to extrapolate it? In the past, people have tended to ignore 10%, perhaps 15% loss to follow-up. Whether they should or not is a moot point. And as you'll see in a minute, perhaps they shouldn't. Whoops, what's happened there? But when you do an imputation, you're assuming that your missing data are random. And we know that we've got a full perinatal data set, and therefore, if we find similarities between those we've seen and we've not seen, then the chances are they might be missing at random. And so we did that, and here's a horrendous table, which you probably can't read, from the paper. But I think you can see quite nicely that actually, if we ignore this lot and just look at obstetric factors and neonatal factors, they're actually very well balanced between the two groups. So it would seem to us that in terms of the perinatal events, they are pretty well matched. But there's something that rang a serious alarm bell for me, and that's this here. You see, those we saw, nearly 3/4 of them were white, whereas only 53% of those we didn't see were white. Now, we, like many countries, have got massive issues with immigration at the moment, and it may well be that these people do not want to come forward for assessment. So if you look at the proportion who needed an interpreter for their 30-month assessment, you see that actually it's 5% versus 1%. And if you look at this mean index of multiple deprivation, which I'll explain in a second, you see also there's a small but nonetheless a whole decile of difference between those. And if you plot it out, you can see which families we didn't get to. And this for me is a really important graph, because here we've got those that were lost to follow-up as the dark bars, and we've got those that were evaluated as the light bars. And this is the decile from the least advantaged to the most advantaged members of society. And you see that we are seeing much more advantaged population. Yeah? So that if you were going to interpret those MDI scores, you actually would say we've overestimated the difference between the two. And actually, having seen that, and it is pretty dramatic to my mind, we should not necessarily be using multiple imputation. So in heaven's name, how are we going to resolve this problem? Well, we resolved it by, I'll come back to that in a second. We resolved it by doing the imputation on the perinatal factors and then doing a regression, so adding in, as Patrick added in gestational age, we added in the decile of your IMD. Now, IMD is a product of the fact that we do a census every 10 years in the UK, and we derive from that census information about the social advantage or disadvantage of your family. And from that, we cluster them by your postcodes. And so as long as I know where you live in the UK, I can make a stab. I hadn't even thought of using that. We can make a stab at knowing how advantaged or disadvantaged you are. It doesn't work brilliantly in some settings, but for the most of the country, when you're dealing with a big data set like this, it's absolutely fine. So that's something we need really to think about. Now, you think that social factors might be important, and people tend to use mother's education and things, but actually they're really important, and we used them a while back. I just thought I'd show you this as an example of how important they might be. We did 2 years of developmental education on families in Bristol. We used something called portage, and to control for the developmental intervention going into the home, we sent a nurse into the home as a parent advisor, and we had a preterm control group with no intervention. And you can see there's an ordinal nature to the three groups, but they're not significantly different. And if we take those with severe disability out, they're still not significantly different. And they're still, as a group, lower than our term control group. And when we went to look at those data, we found that despite the fact it was a randomized trial, there were significant baseline imbalances. And those imbalances were in things like mother's social status, whether they had both parents at home. And so we then did a regression analysis and found that actually these had seriously altered the outcome that we had. And so we then used a regression to put them all together. But you see the size of the effect. If you were in the top to the bottom social class, you had a difference of 6 points. If you had both of your biological parents at home, you had a difference of 5 points. If you had an additional sibling at home, you actually lost 3 points. So this is how developmental scores work. And so we put them all into the regression with our 2 intervention groups, and you see that actually we were able to show positive effect of the intervention. This is a secondary analysis. It's very much post hoc, even though we'd predicted some of these things beforehand. And I would say that's a negative intervention, and I should send myself away to do a better trial. There are people who would take that and say this is very successful, I'm afraid I belong to the Patrick Truffert group, who are pretty conservative about that. And actually, when you use that adjusted score, we then start to see that actually developmental education and home visiting helps children who've got abnormal scans. It helps children who, certainly the portage, helps children less than 1,200 grams, etc. So being able to correct for those things is really important. So they are likely to influence your outcomes. We also know that the group that we're going to look at, if we can't get 100% follow-up, we need to worry. And the reason is, and Dieter Volker showed this in a study some time ago in Germany, the Bavarian population study, that actually those that you didn't follow up actually had many more problems than those that followed up. And Win Tin did it actually in a much more elegant way. He actually followed up 100% of his cohort by driving to the house and waiting outside until they came in and then demanding to examine the child. I'd be probably arrested if I tried to do that now. But nonetheless, it's really important because the ones that didn't respond to his initial contact had twice the rate of impairment of those that had responded. And therefore, had he not really tried very hard, he would have underestimated the impairment in his population. So that's really, really important. So this is what we found in EPICure 2. So these are the children that we saw in 1995. These are the children that we saw in 2006. And you remember we didn't see all of the children in 1995, so we imputed for both populations, so that we started with a level playing field. And in the ones we saw, where we got a full assessment, which was actually only 235, even though we reported 283, you see that actually there are some differences, but they're relatively small. And actually, when we impute the outcomes, that doesn't alter it dramatically. So I think we can be reasonably confident that what we're reporting is what's there. And the only difference there was in the proportion of all admissions who survived without impairment, and that was 23% against 34% in 2006, with a difference of 11%, 6 to 16. And after imputation, actually that didn't change either. So we are fairly confident that we have better outcomes in 2006 than we had before. But the paper reports this lot, and this is the only bit of the table where you see the imputation. And that allows you to put something like this together, where you use your imputed outcomes to produce something people can use in lectures and talk about for a long time, which is quite nice. Now, the other way you can look at your data is to validate it using other people's findings. And here's some findings from the NICHD, and they needed some defining of the EPICure cohort. And actually, when I did that, we had significantly fewer babies in EPICure 2 who had impairment compared even to something 2 years before in the NICHD cohort. And people always hold that out as a sort of a beacon of where we're going. But of course, the other group are the Swedes, who have got immensely better survival than us. And so we did exactly the same, and I took Frederick's normative data, I applied it to my population, and the blue is EPICure, the yellow and orange is Express. I've highlighted the moderate and the severes, and I think you can see that actually there's almost no difference in the outcome between the two cohorts. So I think there is face validity in what we've done from other studies, and we have confidence, having looked at the imputation and then done the imputation with a control for the IMD, the social measure that we had. And that's all I was going to say. I think it's important to understand who your dropouts are. When increasingly we're seeing randomized trials with 2-year outcomes on them, or even 5-year outcomes on them, it's really important to understand that. It's critical to minimize your loss to follow-up, but we have to understand that you can't do that. And actually now I'm about to go and see these children at 19, I may only get to see 30 to 40% of the population. So I've got to be able to be really confident, and because I've got all these data beforehand, I'm pretty confident. I think if you're going to use imputation, you must know that your missing values are randomly present. And I think when you look at randomized trials, just smile at the famous table 1 in a randomized trial with follow-up should be those you've seen against those you haven't seen. And you should look at it and smile when they say they're absolutely the same and they've given you a p-value down the right-hand side. Because the p-value means absolutely nothing, and the p-value can hide huge differences between the population that can bias your outcomes. I think that's a really important, and I see it time and time and time again, because people keep sending me things to review and I keep sending them back and saying, no, you shouldn't do it this way. And I think you have to report what was found and not what you think you might have found had you seen everybody when you come to it. And that's all I was going to say. I hope that was interesting for you. I'm sorry it wasn't a statistician giving you a glorious summation of imputation. Thanks a lot.